So in 20 minutes, I'm going to attempt to just summarize some of the key aspects of managing an acute sickle cell crisis. So this is taken from the soon-to-be guidelines. So an acute sickle crisis, which is what most of you would have had, and it often can be, one of the first interactions with healthcare. It should be considered as a medical emergency, and I think this is one of the key areas where we get things wrong. We still have, even in my organization, patients who are waiting, despite having guidelines and protocols and flow charts, etc., who wait more than the recommended 30 minutes to have their pain relief. So, in pain, this is a medical emergency. So those patients should be, quickly assessed and given their pain relief, and then we can do the rest of the history and so. So the key standard, which is from NICE, is to give adequate pain relief within 30 minutes, and I'll talk a little bit more about that in a second. And then to keep reassessing that acute pain to be until we're on top of things a bit, and then managing the acute crisis, and then importantly, discharge planning to help patients wean their painkillers down. So when patients come into hospital, what things I think are quite key. So a rapid assessment initially. So what kind of sickle cell disease do we have? Where is the pain? Is the pain typical of sickle? I'm sure not because you have sickle cell disease means that the pain can't be from something else. We once had a patient who was pregnant, who was 28 weeks, who was having cramping abdominal pain every 5 minutes, that people said was sickle pain, and then 4 hours later, baby appeared. So, the pain, is the pain typical for sickle cell disease? The duration of onset, was there anything that particularly brought the crisis on? Sometimes there is, sometimes there isn't. And a bit more about the patient's sickle history. Have they had complications like sickle chest crises, for example? Are they on regular transfusions? Have they had a stroke, etc.? And then, of course, other parts of the medical history, medications, including painkillers taken prior to coming into hospital. So what are the key things that we should look for on examination? So are the patients hydrated? Have they been drinking well? Is there any evidence of a fever? It's really, really important. We know that patients are prone to developing infections. Sometimes a low-grade fever, could be seen as a straightforward, uncomplicated crisis, but anything above 38, 37 is normal. Anything above 38 needs assessment for sites of infection, jaundice, and pallor. So we know sickle cell anemia, sickle cell disease has a certain degree of anemia, and patients will have a certain degree of jaundice. So when we speak to the patients, they would know, is this jaundice worse than normal for me? So sometimes somebody might wake up and say, oh, my eyes are much more yellow than normal. So that is really important. So we would then, make sure we check their liver function tests. So what is their heart rate? What is their blood pressure? What is their oxygen saturations? Now, my particular bugbear, and 2 of my patients here would vouch for it, is, the oxygen saturations on air. We should all know what, because coming to clinic and we should be having our annual reviews, what is your normal oxygen level? So for some people, normal might be 91%. So if you come into hospital and it's 91%, that's normal for you. But if it's normally 99% and you come into hospital and it's 91%, then that's a big drop for you. So some of the key things for patients to be aware of: what is your normal hemoglobin? What is your normal oxygen level? So the key things, is make sure when you get copies of your clinic letters, you pay attention to some of these things. Ask your doctors as well. Whether you have whether there's a large liver or spleen. A large spleen tends to be more in children, and that can indicate some particularly serious complications like splenic sequestration, where blood pools in the spleen. And as Dr. Howard sort of mentioned, strokes are quite common. Sickle cell disease is the commonest cause of stroke. So if a patient has neurological symptoms, so numbness on one side, weakness, then we would need to do a neurological examination. So what tests should we do? I'll just summarize this quite quickly. Some of the basic tests. Now, does every single sickle crisis means that patients have a blood test? Not necessarily. So in my institution, we have a day unit and we have accident and emergency. So if a patient comes in with what appears to be an uncomplicated sickle crisis, then perhaps a routine blood test may not be necessary. But certainly if somebody comes in with severe pain, if they haven't been well for a period of time, then some of the basic things that we should be checking would be a blood count. Is the anemia worse than normal? We'll be looking for markers of infection, kidney function tests, liver function tests, particularly to look at what the jaundice level is. And other blood tests will depend on what the clinical situation is. So say, for example, if somebody has an infection, then we would be checking for sites of infection, doing blood cultures, for example. X-rays. Now, I worked out one of my patients had 64 chest X-rays, and she's only in her mid-20s. And you know, a chest X-ray is necessary if somebody has a reason to have a chest X-ray. So if there are signs in the chest, or if there is an infection or low oxygen levels, then yes, a chest X-ray is important. But you know, for a straightforward lower limb pain with normal oxygen levels, then you know, chest X-ray isn't really necessary. And a blood gas, again, you know, doing a blood gas is really painful. I mean, I don't know how many of you would have had a blood gas done. So unless there's a particular reason for having a blood gas, then it's not particularly needed. It seems to be somebody comes into A&E, it's like ER, FBC stat, user needs, chest X-ray, blood gas, this, that, and the other. You know, just sort of think a little bit. And then bony X-rays for straightforward pain that feels typical for sickle pain. Then we don't necessarily routinely need to do bony X-rays because you know, it's only for very specific reasons. If we're looking for certain types of infection or a fracture or something else, we would actually do bony X-rays. Right, so pain relief. The patient is the expert. You know what works for your pain, what things work, what things don't work. And when you are well and in clinic, this is a time to discuss your pain management, because when you're in pain, it's the last time you want for people to be making changes to your pain relief. So all patients, we should have assess pain using a pain score that is appropriate for age. And if there is an individualized care plan, then those need to be referred to. And so those are things that you would take to ED. For hospitals with a large number of sickle patients, you know, there should be a record on the hospital systems. And even so, you know, there are guidelines available, widely available. So there is really no excuse for people not knowing what medications to give. So the aim from the NICE standard, which you've seen this already, is to give sufficiently potent pain relief within 30 minutes. So what have they defined by? So if somebody has moderate pain, so say maybe like a 6 or 7 out of 10, and they've run out of painkillers at home, then a weak opiate such as dihydrocodeine or tramadol might be sufficient for that situation. But clearly, if somebody has had their regular pain relief, like their dihydrocodeine and ibuprofen or diclofenac and paracetamol, half an hour to an hour before coming into hospital, then clearly they need a strong opiate. And the choice of opiate depends on the institution where you work in, depends on allergy history, and depends on what is available. So the options are morphine. So morphine can be given in a number of ways. So it can be given either as Oromorph, which is oral morphine, intravenously, morphine subcutaneous injections. The efficacy is the same. The only difference is that having Oromorph, your body metabolizes a bit of the Oromorph, so the doses might need to be adjusted in acute pain. Diamorphine, oxycodone, fentanyl, which sometimes can be given as lozenges, buprenorphine, which is sublingual. So these are all options of pain, and patients will need to work with their clinicians to find the best way, what works best for them. And then paracetamol as an adjunct. So we're working to the WHO pain ladder. So at the bottom we have paracetamol, and then the non-steroidal anti-inflammatory medications like diclofenac or ibuprofen, which works for the bony part of the pain, then the weak opiates, and then the stronger opiates. So giving the first dose of pain relief is within 30 minutes. That's part of the story. So results in my hospital, so if patients come directly to our sickle unit, then they all get pain relief within 30 minutes. If our patients come to ED, our current time is about 90 minutes, which is really shameful. And this is in a hospital. We see sickle patients regularly. We do training, and so there really is no excuse. So the first dose of pain relief within 30 minutes is important to get right, but then that's not the whole story. So we should be assessing pain regularly, every 30 minutes, sometimes every hour, until we can actually sort of see things beginning to settle. Is the current regime working? If it's not working, what else do we do? Do we think about adding different things? Sometimes that might be adding a PCA, which has its advantages. So different hospitals would have different types of PCAs. Most hospitals would have intravenous PCAs, which sometimes can deliver background pain relief in addition to the boluses that patients need as an extra top-up. The only disadvantage of intravenous PCAs is sometimes venous access is often quite difficult. And if someone is in pain, then, that can be an obstacle, or if the cannula goes in the middle of the night, then that's always a little bit difficult. Some places have subcutaneous PCAs which go under the skin. So again, they can deliver a background, and then they can deliver bolus doses. And the background seems to really help, when the pain isn't settling on boluses of painkiller. Okay, so what other things should we be thinking about? Fluids. Does everybody need intravenous fluids? So again, bearing in mind in adults, venous access is often difficult. So if somebody's unable to drink, then clearly intravenous fluids would be required. So if you are vomiting, or if there's severe nausea where we think you won't be able to drink sufficiently, or if we are unable to drink, if somebody is sleeping most of the time, then clearly they're not going to be awake enough to get enough pain relief. And it is really important as well, and to keep a fluid balance chart. That happens universally quite badly. How much fluids are we having in? How much fluids are we weighing out? Also, if patients have a temperature, then you lose more fluids by sweating. And so if somebody has a temperature, then we have to pay even more attention to fluid balance. Laxatives or the opiates can cause constipation. Antiemetics to prevent vomiting, medicines for itching, and Entonox. We often get asked about Entonox, and long-term use of Entonox can cause neurological concerns. So we say that Entonox use should be limited mostly for the ambulance and maybe for the initially in ED, but really for a short period of time. So NCEPOD, as Joe said, was out in 2008 and looked at some recommendations for improving healthcare. So it said that some of the things looking at, so the NCEPOD report looked into patients who had quite significant complications. So it said some of the things that really needed to happen were regular assessments of acute pain. We need to make sure that patients aren't becoming too drowsy on their pain relief, and that the pain medications isn't accumulating in the system, causing a suppression of patients' breathing rate. It's important that people breathe. Assessing the respiratory rate quite regularly on strong painkillers and also on a PCA. The frequency of observation, so how often you have your blood pressure, saturations, respiratory rate checked, should reflect the degree of pain. So that will be doing pain scores, and also the doses of opiates. If somebody's on a really strong, a really high doses of a PCA, then having observations on at least the respiratory rate and saturations done every hour, I think is important. And all sickle cell patients should have a carefully managed fluid balance chart. As I said, it is universally done quite badly, and a particular bugbears and when the nurses put PU, pass urine, well that's good, but I want to know how much, right? Okay, so so managing the acute pain, how long crises take, it differs for various patients. An important part of the acute crisis management is also how to wean things down. So the pain is settling, and after negotiation with the patient, sometimes when can we stop the PCA? How do we wean the PCA? Do we stop the PCA now? Then do we wean the pain medications down? And it's important to realize as well, on discharge, the pain would still be an issue, and then take things easy for a few days, and continue all the things, continue drinking and continue taking your medications regularly. But then we should also have some clear advice about how to wean those medications down at home, where to get extra medications from, where to get support, and how to manage potential side effects. So this is just an example of what our nurses give patients. So for the first X number of days, which painkillers to take, by about after the fourth day, what medicines to use, and then later on, how to continue to wean things down. And this would be, tailored to suit individual patients. And we've had the contact numbers for our center there. And our lead nurse loves flowcharts, and this is one of our typical flowcharts, which is just describing what the other sort of chart did. So I think that's my complications of sickle cell disease. Okay, so in the initial management of acute pain, now I can't talk about all of these in detail, but quickly, when somebody comes to either to the day unit or to casualty, I'm thinking at the back of my mind, pain, yes, let's get the first source of pain relief done, but are there other things? Is there anything to make me think of sepsis? Anything to think of a chest crisis? Anything to make me think of a stroke? Priapism, painful erections that some men with sickle cell disease get, and which they're often mortified to talk about. Acute anemia, which could be from different viruses or an enlarged liver or spleen, any gallstone type complications, to name some of the few. So this patient is actually in the room. So this is not from somebody who is just made up. So this was a patient she was 17 years old when we first saw her, and first presentation to the hospital, absolutely fine. She had some tummy pain, and everybody thought it was just, pyelonephritis, infection in the kidney, etc. And then by the second day, her breathing was getting faster. Her respiratory rate went up from normal 16 to 60. Oxygen levels went down to about 70-something% on air, and she was coughing up this most beautiful bright yellow sputum, and which was because of sickle cells breaking down in her lungs, and she was actually coughing that up. So all the bits on the right hand side is just lots of what we call consolidation. So lots of sickle cells in that lung, lots of inflammation, plus or minus infection. And by that time she was acutely ill. She went to ITU for a short time, had an exchange transfusion, and got a bit better. So a chest crisis is the second leading cause of admission, and it is one thing that we need to be observing patients carefully for. In adults, it tends to happen by about the second or third day during admission. This is the reason why we pay such attention to oxygen saturations and to the chest signs. And when patients are in, and especially if you have bony pain in your chest or in your upper abdomen, sometimes a machine called an incentive spirometer, which is like just breathing into a device just to help inflate the bases of the lungs, can sometimes help reduce the incidence of a chest crisis. So the management of an acute chest crisis, in brief summary, is pain relief to make sure patients can expand their lung bases, supplemental oxygen. Some patients may need a blood transfusion, antibiotics, ITU review for if we can need to support the breathing, and as I said, transfusions in the majority of cases. Okay, acute anemia. So I said everybody has their unique degree of hemoglobin. So for some patients that might be 50, for some it might be 80. So when patients come in, when we check a blood count, what we're looking for is to see whether the hemoglobin goes down. And if it does go down, then what is it? Is it because of viruses? So there is one called parvovirus, which affects patients with a hemoglobin disorder particularly. Is it because of a large swelling of the liver or a large swelling of the spleen? Again, happens more commonly in childhood for the spleen, before the spleen shrivels. And when those organs increase in size, they can pool blood. Now, okay. So this, you have my pointers. So this is a large spleen. This was an adult patient who was 40, and she kept saying, my spleen is enlarged. And I kept saying, don't be silly, your spleen isn't enlarged, you don't have a spleen. And then we did a scan, and she did have a large spleen, which was the reason why she was having intermittent transfusions every month. So, I felt quite egg on my face. But so we have to keep thinking about various possibilities. And also for patients who've had a recent transfusion reactions causing acute anemia. Sepsis we've spoken about briefly, infections really important. Any fevers above 38, please, as patients, do not sit at home with it. Please call your clinicians. What we don't want is patients to have nasty infections and come to us when you're really, really ill. Sites to consider in sickle cell disease: chest, urine, the biliary system, and bone. And from my last slide, this is a young man. This was the 24th of December. He was wrapping Christmas presents and felt a pain in his leg and had a fever. The pain wasn't typical for his sickle pain. His x-rays here, take it from me, didn't look too bad, but all of this sort of stuff, this white stuff here, is just a whole bone full of infection. So he had osteomyelitis and ended up having 6 weeks of intravenous antibiotics. So priapism, prolonged, painful, and unwanted erection without sexual stimulus. Men, don't be ashamed about it. It is a form of a crisis. It can cause longer-term damage. So, again, if it happens, get some advice from your centers about what to do. Gallstones can occur in about half of patients with sickle and can cause gallstone complications. That's all I'll say about that. And transfusions, I think I've run out of time. Okay.
Come and sit down.